Thank you, Zoe, and good morning, everybody, and welcome to our first panel discussion this morning. Really exciting day for us here at the ODI, and we're going to discuss the importance of involving the public and patients, as well as other stakeholders, in the stewardship of health data in the context of the Insight Hub. We're very proud as an organisation to be involved in this important work, and we look at the Insight Hub as one of the HDR UK's initiatives in an attempt to create a new data institution to address particular conditions and health challenges by involving patients and the public directly in that decision making and ensuring that we have trustworthy sharing of data in the health sector. And by doing so, we then ensure that we reflect patient values, their attitudes, and therefore that should lead to better and informed decision making as well. As Zoe mentioned, I'm Louise Burke. I'm the Managing Director of the Open Data Institute. I'm delighted to be here this morning with my panel members, and I'd like to ask Hilary if she would go first and tell us a little bit about her involvement in the Insight Hub. Thank you.
Thank you, Louise. Good morning, everybody. My name is Hilary Fanning. I am the Managing Director for HDR UK Insight Hub and the Director of Research, Development and Innovation at University Hospitals Birmingham. The HDR UK Insight Health Data Hub is one of 7 hubs set up following a competitive selection process about a year ago now. These hubs are a critical component of HDR UK's mission to unite the UK's health data to enable discoveries that improve people's lives. Insight is focused on eye health and the wider health issues connected to the eye, like diabetes. So maybe to conceive of that as the eye as a window into other biological systems. Insight intends to bring together anonymized, large-scale data and advanced analytics, including artificial intelligence, to develop new insights in disease detection, in diagnosis, in treatments, and personalized healthcare. Insight is a collaboration between 6 partners, and they are University Hospitals Birmingham, Moorfields Eye Hospital, the University of Birmingham, Google Health UK, Roche, and Triple AMD. Thank you, Louise.
Thank you, Hilary. Lee, can I ask you to introduce yourself and tell us a bit about your involvement in the project, please?
Of course. Thanks, Louise, ODI, and organizers for the invitation to share some of our views with you. My name is Wenhua Li. Call me Lee for simplicity. I'm the Chief Executive and also Chief Scientist at Action Against Age-Related Macular Degeneration. A mouthful, and that's why we call it Triple AMD. Triple AMD is actually a collaboration founded by 4 different charities: Blind Veterans UK, Fight for Sight, Macular Society, Scottish World Blinded, because they together saw that the biggest challenge in the sight loss sector will be the oncoming wave of people with age-related macular degeneration, AMD. So my role with the Insight is that I am one of the partners, and I bring into the Insight the dimension of a charity partner to this fantastic initiative. And together with the Insight leadership team, and also working with ODI, we are leading the development of a new framework to include meaningful public and patient participation in Insight's governance. And we also act as an interface between the Insight executive and leadership team and the broader public and patient involvement and engagement network. So that's me in a nutshell.
Thank you very much, Lee. Rob, can I move across to you then, and for you to tell us a little bit about the hat that you wear in the context of the work here?
Of course. Thank you, Louise. So as Louise said, my name is Rob Bryan. I'm a partner and one of the owners in a law firm called BPE Solicitors. We have a unit within the practice that is dedicated to supporting primarily, but not exclusively, publicly funded science and technology, engineering and mathematical organisations, STEM organisations. For the last 10 years, we've been involved in establishing many of the major publicly funded initiatives like catapults, like the Open Data Institute, and also the formation of Action Against Age-Related Macular Degeneration, of course. We are particularly passionate about opening up access in a variety of for a variety of assets for the common good, none more so than data. And that's one of the reasons why we're so keen to be involved in this particular initiative.
Thank you very much, Bob, and thank you to all my panel members for that background. Now we're going to get into some of the questions, specific questions, and I'm sure our audience will be really curious to hear more about. So Hilary, if I could start with you again, feels like I'm picking on you, but if I could start with you again, I'd be really interested to get your views on why it is so important to involve the public, patients, and other stakeholders in the stewarding of this data, and what are the pitfalls if we weren't to do it?
Okay, great question, and clearly absolutely pertinent for this conference today. I think what I would start with saying is that we were absolutely clear right from the start of our journey toward both describing and setting up Insight that our North Star was to use data responsibly and transparently for patient benefit. So absolutely clear from the outset that we both wanted and needed patient and public involvement. We wanted patient and public insight and their oversight and scrutiny of the work of the hub. And that's, I guess, a reflection also of the, if you like, the seriousness with which the two NHS trusts take the responsible management of data that is generated from healthcare contacts. We, as the two NHS trusts, had a long track record also in patient and public involvement and engagement, in research activities, and more laterally in this particular space of healthcare data research. And we know and knew when we were preparing this bid from both the patient and public engagement work at Moorfields and at University Hospitals Birmingham, and of course some of those findings more laterally borne out through the fantastic work of the One London deliberative inquiry and the work of understanding patient data, that patients expect us to share data that we collect about their clinical conditions and care, but they also want to know how that data is used. And they want to know who has access to it. They want to know that it's being handled securely and what the use of that data means for them as an individual. And also what the use of that data might mean in terms of return of benefit to the NHS. So if you like, the what, the who, the why, and for what purpose is that data being used? And I think the second part of your question was, well, what are the costs of not doing this? And there are, of course, legal, financial, and reputational costs for organizations of getting stewardship of data wrong. But perhaps a really important point is that loss of patient and public trust. And I think you're going to hear this word a lot during today's sessions. So the loss of trust in the work we are doing would be a significant cost and, quite frankly, an abject failure on the hub's part. So it's really important, therefore, for us, and it's absolutely part of our mantra, that there needs to be close involvement of patients, the public, and other stakeholders to enable us to ensure, as we make the Insight Hub functioning, that we adhere to the 5 safes. So safe data, safe projects, safe people, safe settings, and safe outputs. So we have welcomed the work of ODI and the input of AAAMD as a charity partner to keep us honest and to ensure that we are always referring back to that North Star of patient benefit. If we want to understand patient benefit, we need to ask patients what they understand by patient benefit and involve them in decision making around the use of their data.
Thank you very much, Hilary. And that brings us very nicely into a little bit of the story and the narrative behind the journey that ODI has been on with AAAMD and our involvement in the project. Lee, I mean, you've been there right from the very beginning. I think it might be just over a year now that we've been working actively on this project. So would you like to give us a little bit of the history and the roles that we contribute as organizations?
Of course, it will be a pleasure. So I think the right way to tell the story is really looking at AAAMD's mission. We were formed because AMD, I mean ophthalmology now is the business outpatient practice in the NHS. And with AMD, age-related macular degeneration, driving a large amount of people seeking the services. Now, with an aging population, we'd expect this number to grow even bigger. But the challenge for all of us is that we see the word age-related and we don't think much about it. No, most people don't think much about it. And we hear here and there saying, oh, yes, there is a treatment. However, what people don't realize is that the treatment only addresses a small amount of the potential number of patients that start to develop the condition. So there are some estimates out there which project at the number of UK population having some early signs of AMD at more than 8 million people. Yet, only 250,000 are treatable with the only existing treatment. So instead of waiting for that onslaught of large number coming with the aged population and overburdening the NHS, my trustees asked me to find a solution so we can actually move the focus into early. How can we detect earlier stage of disease, and how can we actually stop it from progressing into this late stage, which is more challenging, which threatens the sight? And in fact, AMD is a leading cause of legal blindness or sight loss in the UK and the developed world. Now, the challenge is that how do we move from the traditional, typical firefighting mode, which many of the diseases are tackled at the moment, into something that is more into preventive and stopping it from getting worse. So disease understanding. The challenge is that we don't really understand early disease. We don't understand how the disease really evolves. And as a consequence, availability of data is paramount to get that out there in the hands of academics, in the hand of scientists, be it in academia or industry, so we can together find the best way to address the problem. Now, right earlier on, we thought, yes, there's a lot of data out there, but the biggest challenge really is with regards to trust and trustworthiness. With a lot of news pieces saying, oh, be careful with big data or those scary stories, I think what happens now is that there's a little bit of, let's take a safer position, but that comes at the risk of not being able to progress the science as fast as it should or it could. So together we started looking into what might be the best way to unlock that potential. How can we build trust? How we can include trustworthiness? How do we bring public and patient voice into this? This is how we started working early on with ODI on the concept of a data tab. We call it data tab, which is Data Trust Advisory Board. And as we were developing this, many of the leaders in the field, clinicians, NHS Foundation Trust, industry, we're looking at also how to tackle this challenge. This is when MMD and ODI's work intersected through different conversations with this nascent concept of the Insight Hub. And then we put the two together, and that came out much bigger than 4. So we started building how we can bring some of the work we've done earlier on with ODI into the framework that Insight would like to deliver to bring those data sets to be used. So that was a very fortunate and well-timed event. And these actually led us to co-create this concept of a data trust advisory board. In this sense, what we've done is to create a layer where decisions on whether any applicants to try to use the data set goes through a more technical check by the Insight, as per many of database applications or database access. But then before they are fully given access, this goes into the data tab, who can then discuss and deliberate on more of the less established, if you like, kind of questions. We're not asking things like whether a applicant or user has a track record of using the data safely, for instance, but rather in understanding whether in their proposal there seems to be a clear line of sight into public benefit, a clinical benefit, things that are less well defined, but yet need that kind of input from both patient and public. We can talk a little bit more about how Data Tab is built, but that actually is where we are at the moment, developing this layer, this Data Tab, where we then get back to the Insight leadership team and say, application A, application B, we checked, we asked these questions, and it seems to fulfill or check some of the boxes that the public and the patients would like to see addressed or at least considered before the data is actually given out to the applicants. I hope that, in a nutshell, resumes what we are trying to do here and what we're trying to lead with ODI in this data tab work.
Thank you, Lee. And as you said, we'll come to talk a bit more in detail about the data tab later on. Rob, moving across to you, it would be really interesting to understand some of maybe the legal challenges or some of the challenges around involving public patients in this kind of decision making, depending on the environment that they're working in. So looking at the health environment, for example. I mean, you know, what sort of things come to light?
So thank you, Louise. So I'd start by reiterating what Hilary and Lee have already identified. It is that issue of trust with a lowercase t, and how you go about maintaining that and giving people sufficient assurance. I think the nature of the challenges are going to change as the form of the data trust changes too. As you know, at the moment it is simply an advisory board. There is an expectation that the data trust will morph, will evolve into a separate legal entity over time. And when it does, the level of controls and the level of legal challenge that we will have will be greater. But I think it's important to give people assurance that now, even in its current form, that issue of confidentiality is a fundamental legal issue that's been addressed by the data tab. So members aren't permitted to share information that's related to any data access requests that they've assessed and made a recommendation on until the minutes for the meeting in question have been published. So transparency is absolutely key. So there's that tension, if you like, that where we're trying to ensure in a way that's consistent with the ODI's philosophy of being open and being transparent, but also providing people with that assurance that the information is being held in a secure way. So once those minutes have been published, members can then only share information that's contained within those publicly available minutes, and they're not permitted to share any other confidential information that they may acquire in undertaking their role. So I think issue of confidentiality is the first point I would make in relation to now. Then moving forward, as I say, because it's only an advisory board, there isn't actually a need to limit individual liability for directors at this stage, because there isn't an entity, but they're actually directors of. But when we create a formal legal entity, then we'll have to limit the liability of individual members who are making decisions on the data, and there'll also have to be controls on the limitation of liability of those directors. So to answer the exam question, what are the legal challenges now? They're actually relatively few, because the data tab isn't a decision-making body. But once we've moved towards that full legally constituted data trust, there will be a whole load of considerations. We probably would recommend that we create a company limited by guarantee. That hasn't yet been approved by the Insight Hub, but hopefully that will happen in due course. And by creating that separate legal entity, in common with all companies, what you're doing is you're then limiting liability. And if you can limit that liability, you're going to encourage people to share information more readily. So the involvement of the public, the patients, all stakeholders, to determine who can have access to the data, to the data sets. That's very important to make sure that ethical, comprehensive decisions can be made. But balance against that, you've got to ensure that those individuals are protected from risk and liability. Directors are subject to duties. They've got to avoid conflicts of interest. They've got to promote the success of the company. Those are things that exist with all entities. And then, as you'll be aware, obviously GDPR, the General Data Protection Regulations, have to be taken into account. So there's issues of privacy, particularly if the data can't be fully anonymized. Now, the GDPR is a high legal standard to meet, and if there's a breach, then it could be financially and reputationally devastating. If we've got within the Insight data, I anticipate that it will be pseudo-anonymized data, so it will fall within the GDPR. So one of the legal challenges that we'll have is we'll need to establish a data protection officer. Finally, I just mentioned briefly the need to consider competition law, because we'll need to make sure that the data trust will ensure that it meets conditions so that it's not, but they're exempt from a breach of the prohibition of the Competition Act, because there may be anti-competitive measures on setting of prices and the terms and deciding who will share the data. So those conditions are all going to need to be met. And we've got to promote technical progress, and for it to be consumer benefit, and to be no more anti-competitive that's actually necessary. So those are, I think, are the key legal challenges, Louise.
Thank you very much, Rob. Moving across, Hilary, then taking some of that information forward from Rob and Lee. When you look at the formation of the data tab, how does that fit with other public patient involvement work that you have at the moment?
If I could just reflect back on both Rob and Lee, I mean, I think that the key theme there is we are on a journey. You know, we have a destination in mind, but you know, we might get to that destination, or we might have a different model. You know, so that destination might look slightly different. And I think Nigel made the point early on in his introduction to this session, you know, that there probably isn't one model fits all for how structures like data trust advisory groups or boards might actually look. So that's one point. I think the other is that this key theme around patient and public involvement and engagement. And I think what I would say is that we see the work of the data tab and the work of the PPI groups that have been put in place as part of the Insight Hub. Well, they're absolutely critical components of our approach to building and sustaining trust in the work of insight. They're critical components of the framework of risk assessment, risk mitigation. They are critical components of ensuring that we have reach across different stakeholder groups. And I could maybe just give an example of how that might work, for example. So we see these working hand in glove. So, for example, questions or concerns that arise from the deliberations of the PPIE group with respect to either the appropriateness or the safety or the potential benefit that might arise from different types of data use request. So where those questions arise, then those questions can be flagged to the data tab. And the data tab can take those questions, queries, concerns into consideration when they are reviewing data access requests. So if you like, they will review those, I think, in tandem with working out around whether the use requester has answered those questions, or whether in fact we need to go back to the requester and say, you haven't answered those questions adequately. These are additional concerns that we think you need to think about and address, and then come back to us. So this kind of symbiotic, if you like, symbiotic relationship where the data tab is learning from the PPIE groups are learning from the data tab, but also where those outputs are also informing how the data controller manages the safe stewardship of data. So it's really important that outputs from the data tab and the PPI groups in this space are also fed back to the data controller, so that what we're talking about is developing a learning system. I said, we're on a journey together. We're developing a learning system about the safe and responsible use of data with a wide stakeholder grouping. And that learning, we can use that learning in a whole range of different ways. So, for example, we can use the learning, the outputs from the work of the data tab and the PPIE groups to plan our communications, to plan and identify where we may have gaps or deficits in our communications. We can use that to plan educational events. We can use those outputs to identify, if you like, training and development needs, be that for the data tab members or for our PPI group, or indeed for any of the staff that are involved in the work of insight. So I think those are real kind of key examples of how we see this working together. And there are other uses for some of the outputs that we're already beginning to see emerge. So, for example, the feedback from the PPIE groups is informing how the NHS trusts that are involved in this shape their privacy notices. The feedback from the PPI groups has identified that actually, national data opt-out is not a concept that's either well understood or that has penetrated very well across the public. So I think all of these things together, these are key parts of the story that we need to engage with patients on, and they need to be authors of what our solutions to those are. So hopefully that explains how I think we see both the PPIE piece and the data tab piece working together, Louise.
Thank you, Hilary. I think Lee is keen to come there. I saw the hand waving.
Yeah, no, I just want to add a big highlight and a shout out to actually both the NHS Foundation Trust with the Insight, that is the University Hospitals Birmingham and Moorfields Eye Hospital NHS Foundation Trust. I mean, as Rob rightfully said, Data Trust Advisory Board at this stage has very little liability, if you like. And it is really, really stimulating to have two large NHS Foundation trusts to leave their zone of comfort and start to work with us on what could be the next type or stage of including public and patient opinion into the governance. I think this is actually comes with a lot of risk as well, a lot of liability. And then we're really thankful for them to come up and start to trialing those many different new implementations with us. And Hilary is absolutely right. And when we get the input from PPIE, from public and patient engagement involvement groups, it is interesting that we did see some calibration, and that Data Trust Advisory Board, Data Tab, we've asked them to come up with the questions. And very interestingly, both exercises conducted separately, they are so in sync. So we are confident that the tab is already representing a much larger scale of population. And of course, the big question of how to involve PPIE into governance is, wait, we cannot bring all the thousands of people and have them to vote, right? That doesn't work this way. However, Data Tab is somewhat this middle layer, which will be able to capture that public and patient feeling and help us scrutinize some of the data access requests that are put in. More importantly, I think two final quick points is that the frequency of Data Tab meetings, it will be quarterly. And that's important because as we move into very high technical off-the-box thinking from many innovators, it would be almost irresponsible to come with just a static set of rules that would stay there for the entirety of the project. That would never capture the potential of innovation that would come through our doors, one. So these more frequent meetings will give also a lot of flexibility in analyzing this. The second bit is, how do we bring, and at the moment Data Tab has 10 members, how do we bring 10 members to start to look into very broad and wide proposals that are coming in, but also capturing, the broader population's sense. Instead of us doing this, let's pick one representative from 10 selected institutions, for instance, we went out to set up the Data Tab membership based on citizenship. Each one of them are in the Data Tab as citizens. They're not representing any specific institution. And when they are there acting as citizens, they actually bring many of their previous experience and present experience on the table. So in the end, what we're covering with 10 members is that if we think, for instance, we do have a member, for instance, that actually participated with the National Institute for Health and Clinical Excellence, NICE, one of the regulators, if you like, is an expert in social sciences and policy and also health services research. One person, we're bringing that many expertise who can actually help us cover way more dimensions than just one single unilateral review that would be typical of one person representing one institution. In the panel, we do have people representing both public and patient, academia, industry, charities, clinicians, public affairs, politics, regulators, journalists, ethicists, and also even ex-politicians. So these are really rich kind of background to help us navigate those proposals in the most efficient way and transparently. I have to say that's the most important thing.
Thanks, Lee. We've got absolutely lots of participation from the audience, which is really great. So I'm just going to pick up a couple of questions. I know that we haven't got a huge amount of time. So one of the questions is around parity. So what happens if the interests of patients and citizens, the public sector organisations and commercial organisations conflict? How do we unpick that one? Not sure who wants to pick that one up. Hilary?
Oh, thank you, Louise. That's a great question, whoever that has come from. I mean, I think I would just frame that by saying, where you have situations of conflict, then there needs to be understanding of what the source of that is. So why is there conflict? And very often, at least this is my experience, where you have contentious situations, it's helpful to try and go back to first principles. So what is it? What's the common ground? What is it that you're trying to do? What do you think the benefits are? And to negotiate and to try and come to common ground, common understanding. I guess you need to take everything on a case per case basis. I don't know. I mean, it would be useful to look at a specific example and work through how you might approach it. But I suspect it's one of those situations where there won't just be that's the solution. But I think key thing for me is what is the common ground? What is the baseline that you're going to have discussion and negotiation on? And then I think from there, you will find a way through, take a view. That might be to do something, it might be to do nothing.
Thank you, Hilary.
It'd be quite nice if Lee or Rob could add to that.
Yeah, over to you, Rob.
Rob go first.
Okay. So I think the first thing I would say, and I echo what Hilary's already said, but in the terms of reference that have been prepared for the data tab, we've anticipated that potential problem, and ultimately, the chair of the data advisory group will work with the chair of the steering group to respond to those concerns. What we're absolutely committed to ensuring is that people, although they may represent a particular section, whether it be patients or in industry, etc., they have to think about the totality and the whole, and that's why the ultimate power is given to the chair in that respect. Lee, you wanted to add?
Thank you. May I just add to the excellent points that both have made, is to say that one of the objectives of Data Tab is to create a safe space where we don't have us against them. So many of these questions about patients not being in sync with industry stems from a lot of misunderstanding or lack of information. Many times what the public would like to see, there's a great clear explanation of why they cannot be implemented due to either regulation, due to either increased level of protection of privacy and so on. I think the Data Tab's role, it is all about bringing to the table that, look, that's something that this group wants. The other group is already on the table trying to explain and work together why this has been tried before and perhaps doesn't work or does work. So it's always try to come up with a consensus there. And that's the important thing. When we were designing the Data Tab member composition, we did it in a way that we were careful not to have any specific group in a number or power that can outvote any other group. So we don't want to create voting blocks, but spread it really out evenly. For instance, one of the members we have actually worked in an industry before in the policy team, but now represents or has actually quite a few hats on both on the public side of policy, but also with the AMRC, which is the Association of Medical Research Charities. So they can bring some of those views from insiders' previous experience, but without present conflict. So this is actually the way we'd like to solve this. And a good, if you like, disposition from what people might believe, industry, they would never go for transparency. I have to say, good surprise, that's not true. Our industry partners, they are very happy for the Data Tab's decisions and deliberations to be made public and transparent, and that's really a significant step. So I think we're looking into a very new zone or a new space where many are trying to come with the best intention and find the best solution where all the inputs are considered. And that's how we try to implement into the Data Tab operations.
Thank you, Lee, for that. Oh gosh, such a shame. There's some really fantastic questions that are coming through, so perhaps we can deal with some of those in the various breakout rooms where some of our panel members and ODI team are present. So we will try to provide those answers. It's been absolutely fantastic and fascinating and really interesting to hear about the Insight Hub and the work and the involvement and the history of it all and the direction of travel. And as Hilary said, you know, where it goes or where it settles will evolve over time as we move forward. I'd just like to hear very briefly from each of you one takeaway message from you for the audience about your particular area and involvement in the Insight Hub. Rob.
Have confidence in the law. I guess is my take out. People will know that data cannot be put into a trust in a conventional sense, and some people in the past have said, well, that's a good enough reason not to progress with these things. There are a variety of models. People are well used to entering into contracts for data sharing agreements, but actually, as I've mentioned already and others have commented, we can create corporate models that I believe can provide people with the necessary assurance, confidence and trust to enable these data sets to be opened up for the public good and to help achieve what Action Against AMD is trying to achieve here in the Insight Hub.
Thanks, Rob. So close to the law. Over to Hilary.
I think what I would say is I feel very privileged, actually, to be part of the team that is Insight. I feel very privileged to be in the position that I'm in, to help drive forward the use of the responsible use of health data for research purposes here in this country, but also privileged to have such fantastic patient input, to have such fantastic public input into the work that we're doing. And I would also like to add reassurance that we take that really seriously. The importance of our patients is absolutely paramount.
Thank you, Hilary. So feeling very privileged, as the ODI does, supporting this particular project as well, but stressing that there is great care and consideration and the importance of patient data. Thank you very much, Hilary. And Lee?
Yes, I mean, just as Hilary, I think we are all very excited to be living actually in the future, right? We are already in the brave new world where we can see data being used in such a powerful way. And I'd just like to, one last comment is to remind everybody that innovation, especially in this domain, has experienced an enormous acceleration. Yet regulation and public opinion seems to be a little bit lagging behind. A little bit understandably, as no one wants to be steamrolled into something that one doesn't understand. But I think it's really important to recognize that simply blocking or stalling those efforts will not solve it, and actually might end up perpetuating the harm posed by not seeking new or improved treatments and therapies. And that's why the importance of the Insight, the data tab, the work that the ODI is doing, and actually a shout out to the Health Data Research UK, which is kind of a national framework coordinating all this effort, not only ophthalmology, but in many other domains. I think we are leading this, and the quicker we can do it in the safest way, the better we can ensure that not only the patient will benefit from it, but also the public. Because one thing is certain, we will all become patients one day. We will hit a disease for which there's no treatment. So it's best to do it now while we can, rather than try to firefight and run after losing game. So that's my take-home message. Thank you, everybody.
Thank you, Lee. So big message there, you know, responsible stewardship of the data to address those big challenges health challenges that face us in the future. And I'd like to just say thank you very much to all our panelists. Thank you, Hilary, Lee and Rob. It's been a really engaging 45 minutes, and I hope that the audience has benefited from our session too. So I'll hand back to Zoe, and cheerio everybody, and have a great day.